Here we are. So tonight's presentation is called Enabling Aging Well in Canada. And really, there are three goals for tonight's presentation. We've got three objectives. One is to understand what the pandemic has taught us about the state of long-term care in Canada and what we need to do about it. Two, to appreciate how aging well needs to begin with the development of age-friendly and dementia-friendly communities enabled by a national senior strategy. And three, provide some practical advice on how individuals can enable their own healthy aging as well. So right now, we're contending with the fact that we're seeing an uptick, sadly, again, in our fourth wave of outbreaks occurring in our long-term care homes across Ontario and across Canada. Just about 2 months ago, there were only 10 homes across the country that were experiencing outbreaks of COVID-19. And just as of today, we have well over 200 that are currently experiencing outbreaks. And the key is, outbreaks and these issues in our long-term care homes are not a relatively new phenomenon. This was some work that was done by Victoria Gibson, a journalist, who took a look at all the data between 2014 and 2019, so before COVID, and was able to take a look at where we were seeing respiratory outbreaks occur. And you can see over that time period, about 2/3 of the outbreaks occurring in Ontario were always occurring in our long-term care homes. And then about 20%, or 1 in 5, were occurring in our retirement homes. And so really, we've always known that these have been environments where we've been seeing a higher rate of outbreaks occurring for things like influenza, rhinoviruses, and other coronaviruses, not necessarily COVID-19. And so it really wasn't a surprise when we started seeing the significant devastation of this pandemic and its influence on long-term care homes in particular over time. And really, when you start thinking about how we probably were normalizing the rate of respiratory outbreaks, we appreciate that we know that our long-term care homes weren't really well prepared to endure a pandemic. And this pandemic has really exposed long-standing vulnerabilities in our long-term care settings. This is a report that I helped to write last year, and it really focused on the fact that we have now all come to know that there's been chronic under-resourcing of these homes. There is a rising acuity level in the residents in these homes. People are more likely to be living with dementia. People are more likely to be living with significant medical problems and other health issues and mobility challenges. We've known that about 1/3 of the homes in Ontario have been built to 1972 design standards, and 1/3 of the homes in Ontario have up to 4 people living in a room. There's always been long-standing staffing challenges in these settings, partly because many of the staff in these settings are not paid full-time wages or offered full-time work. And we also know there's so many other things that are going on here. In fact, that seeing that high numbers of people coming into homes with limited infection control measures and insufficient infection prevention control training and practices, all of these things were really contributing to how these homes really started to struggle very early on during the pandemic itself. And when you actually look at the data, this is data that my research team at the NIA has been dutifully collecting since the beginning of the pandemic, as we've been tracking the outbreaks that have been occurring in long-term care and retirement homes across the country. And so we have this, we have a website called our COVID-19 long-term care tracker. And this is where you can actually see all the data that's actually happening across the country. And sadly, we've seen over 200, close to 3,000 homes in Canada that have been experiencing outbreaks. And you can see that in the two highlighted above. I always say this is a tale of two provinces, Alberta and BC. You've had two provinces that have had very different approaches to how they've approached their pandemic, even though they have similar sized populations. Yet you can see that Alberta overall has experienced a higher degree, a higher percentage of its homes over time have experienced outbreaks. 71% of its homes have experienced these, almost double the rate of what we've seen in British Columbia. And we've certainly, sadly, seen far more deaths in Alberta than have occurred or in BC. And BC is a population that has a larger province than population than Alberta. So all of a sudden, you can see that we've had variable performances throughout the pandemic and in our long-term care homes as well. And really, when you actually think about how Canada ranks against itself against the rest of the world, this was a study that I did with colleagues where we looked at Canada versus 11 other industrialized countries. And what we showed overall was that if you were an older person living in Canada, you had a significantly higher risk of getting sick compared to a younger person living in the community. But where we saw a significant difference was that if you were living in a long-term care retirement home in Canada, you had a 74-fold difference. This is Canada right off to the far right side, a 74-fold difference of getting COVID if you were living in a long-term care or retirement home versus living in being an older adult living in the community. And so it really helped us to signify how Canada's homes were almost 3 times as likely to experience outbreaks from COVID-19 as what we were seeing from the average around the world. And so this really spoke to how Canada was really seeing significant challenges in managing COVID in its homes compared to other jurisdictions as well. So what we do know is that the pandemic has really shifted Canadians' perspectives on how they want to age and where they want to age. We know that 97% of Ontarians in particular believe that there's a crisis in our long-term care system. 78% of Ontarians have further said they would prefer to receive home care for themselves and their loved ones over care in a long-term care home. 60% of Canadians and almost 70% of older Canadians have further reported that COVID-19 has changed their opinion on whether or not they'd arrange for themselves or an older loved one to live in a nursing or retirement home, while 57% of Ontarians, so just the majority, do not believe that they'll have access to good quality long-term care when they need it. So this is not really painting a great picture of our faith in our current long-term care system, and really it helps to explain why so many Canadians are determined to age in their own homes and communities for as long as possible. So how do we enable the future of long-term care in Canada, and how should we look at it? Well, we have been writing about long-term care and in various reports, and in 2019, the NIA put out 2 reports, one called Enabling the Future Provision of Long-Term Care, and another one called The Future Cost of Long-Term Care, helping to really paint the story of what needed to be done and what the issues actually were. And really, this relates to the work that we've been doing to try and promote the idea of a national senior strategy that really focuses around this 3rd pillar of recognizing the fact that the vast majority of Canadians want to receive their care in their own homes whenever possible and as close to their own homes as possible as well. And so we really explored these issues in greater depth. And one of the things we talked about was helping to kind of redefine what we think about as long-term care, because long-term care is a term that's used in Ontario in particular, really refer to nursing home care. But if you go anywhere around the world, for example, when they talk about long-term care, they really talk about a whole continuum of care that exists, for example. So the idea is that, if you look at the top row here, we talk about the provision of what we call ADL and IADL supports, for example. So ADL supports are those supports with your basic activities of daily living, like bathing, transferring, toileting, eating, getting dressed, etc. When we talk about IADL supports, for example, these are those higher order tasks. These are things like using a telephone, making a meal, for example, taking one's medications, doing the grocery shopping. So we recognize that people, as they age, might have a whole spectrum of needs, for example, and that these are needs that could be delivered by either a paid care provider or an unpaid caregiver. We also know that where people need to receive this sort of long-term care can exist either in designated buildings, such as long-term care homes, or it can even be provided in a person's own home or in a community-based setting. And so this is where we talk about care and support that is provided in a variety of locations, and it could be provided by a not-for-profit or a for-profit provider. And finally, we talk about the notion of what we call preventative and responsive care. Preventative care talks about care that we can do to try and help a person get back on their feet and return to being independent. So this might be helping a person get rehabilitation so that they can bathe themselves once again in time. And responsive care means really kind of responding to a person's challenges. So if they can't bathe themselves, we're going to respond by helping them to bathe, for example. And these are types of care that can be supported by primary and specialty care providers, for example. So this is kind of how we think about the provision of long-term care in Canada, and as it's really conceptualized in other places around the world. And I think it's important to think about long-term care as something that can exist across the continuum, rather just in a designated building like a nursing home. And why does this care matter? Why does long-term care matter? Well, it's the largest form of hands-on care that is not currently covered under the Canada Health Act. And that's important because, again, many people go throughout their lives realizing that if they need a physician's care, they get that covered by OHIP. If you need to be in a hospital, that's all free of charge. It's all guaranteed under the Canada Health Act. But long-term care, for example, and pharmacare, for example, these were things that were covered under the Canada Health Act. And this is a challenge because we don't realize that these things aren't covered until we may not actually need them later on in life. And by that time, we may not have saved up enough money. We may not have made the right preparations to be able to access the right amount of long-term care that we need. And this is a challenge because when we leave it to the provinces and territories, we see that coverage levels and qualifying criteria and design and other standards vary significantly across provinces and territories. And we know there's a growing value of these services to meet the long-term care needs of an aging population effectively and sustainably. So we need to think about how we actually think about the provision of these services, because these will help to keep our overall system more efficient and sustainable. And the current demand for long-term care services is already unprecedented and is only expected to grow as the population ages. But we know, as I mentioned before, the system has been plagued by long-standing systemic vulnerabilities when it comes to health, human resources, and physical design and redevelopment approaches. So we also know that when we've looked at surveys over the years, there was a 2015 survey of 2008 people that found that 63% of Canadian respondents said their family was not in a good position, either financially or otherwise, to care for older family members if they needed long-term care. And this worried them greatly. So we know that it's not just simply something that we can just wait for family members to pick up the slack or people to be able to say, well, pay for themselves, because we know that many Canadians are not in the position to actually do this. And here's the challenge: when we actually have an underfunded long-term care system, a system that's not providing enough home and community care supports, for example, we know that we then end up having hundreds of thousands of Canadians that report currently having unmet home care needs. Well over 40,000 are currently on a nursing home wait list as well. And you can imagine if you can't get support in home, then you're going to end up in a nursing home, for example. And so we can start seeing that probably if we start looking to provide more home and community care, less people might need to go into a nursing home altogether. And certainly the Canadian Institutes of Health Information has done a variety of studies where they've shown between 10 to 30% of the people who are entering long-term care homes today probably wouldn't need to be there if there was more adequate home and community care services being provided. So remember how I talked about Canada and where it ranks with the rest of the world earlier on. This is another study that was done by the OECD, or what we call the industrial rich nations of our world. And really this looks at Canada compared to other countries. And this looks at how much we spend as a proportion of our GDP, or gross domestic product, on the provision of long-term care. If you want to find Canada, you can actually see it right here in the middle. I'll just get my laser pointer out here. So you see Canada right here in the middle, symbolized by the maple leaf. And you can see that we spend about 1% or 1.2% of our gross domestic product on the provision of long-term care. Now, if you want to find out where the average is for the OECD countries, you can see over here, the average OECD country spends about 1.7% of its GDP, so about 30% more than what Canada spends. But I want you to focus on this country over here, the country of Denmark, because they spend about 2.5%, or about twofold what we spend on our GDP on the provision of long-term care for its population. Then when you actually look at how we spend our long-term care dollars, what you can see is that we then note that when you find Canada here, you can see 87 cents of every long-term care dollar gets spent on having people in nursing homes, for example, while only 13% is provided for the provision of home and community care. So you can see that Canada, once again, is an outlier. But when you look at the OECD average here, you'll find that the average industrial country spends about 2/3 of its funding around the provision of nursing home care, but only 1/3 on the provision of home and community care. So much better than what we do in Canada. But remember Denmark, that country that was far over to the left of your screens in the previous slide? Well, now it's far over to the left of your screens in this slide, because Denmark actually uses its funding around the provision of long-term care and actually spends 2/3 of it on caring for people in their own homes and only 1/3 of it for providing care to people in long-term care homes. So there's real different approaches here is what I'm trying to point out in terms of how we can better care for an aging population. And of course, people say, well, I guess that's how we structured it. And what's the big deal? Well, the big deal is this costs a lot of money. So right now we're spending currently about $22 billion a year on the provision of long-term care services, both home and community care and publicly funded nursing home care. The green here represents public home care costs. The blue represents public nursing home costs. And you can see that this is a projection from 2019 all the way to 2049, so a 30-year period. And what you can see is that if we continue to spend only 13% of our funding on the provision of home and community care, the bulk of our funding will be spent on providing more expensive nursing home care. And if you want to know what this dotted blue line here is, this basically shows that what we're going to be spending by 2050 is going to represent about 1 in 5 income tax dollars, both federal and provincial. So these costs are going to nearly triple over the next 30 years and significantly represent a huge amount of our overall long-term care, of our overall taxation and personal income taxes. So this really, in other words, ladies and gentlemen, is not a sustainable model. And as I mentioned to you before, over the next 30 years, it's going to the cost of providing care is going to grow from $22 to $71 billion. We also know that people might say, well, that's fine. We'll just have our children take care of us. And maybe the government's thinking, yeah, that's fine. We'll just have more sons and daughters pick up the slack, for example. But we know that over the next 30 years as well, there'll be approximately 30 fewer close family members available to provide unpaid care to older members of our society. So not only do we not have enough money to afford to age in the places of our choice, we're less likely to have other people we can rely upon. And right now, our government is currently considering just having us live in nursing homes as opposed to really focusing on the provision of more home and community care. So when we think about, how do we start thinking about how should we look at providing long-term care in Ontario moving forward? And so this is a complicated diagram. You can see it looks like a bit of a pyramid, if you will, but it's not a pyramid scheme, I assure you. But this is a bit of a conceptual framework that my team developed at the NIA, really talking about what we could do to try and support people to better age in the place of their choice. And it really recognizes that people will have different states of health as they age, for example, and therefore be able to live in different care environments depending on the types of services that we can put in place. And so the very bottom of the actual pyramid, if you will, speaks to this notion, for example, of things to support people to continue to live independently in their own community, for example. And so the first thing you see on the list is this concept of age-friendly communities. And I just wanted to pause here to help remind us what age-friendly communities are all about, because this is what the World Health Organization defines an age-friendly community to be. It's a community that recognizes the great diversity amongst older persons. It promotes their inclusion and contributions in all areas of community life. It respects their decision and lifestyle choices and anticipates and responds flexibly to aging-related needs and their preferences. And you've heard about the term age-friendly community. It's a concept that's been alive and well for over a decade now around the world and across Canada. But also, it also can consider this concept of dementia-friendly communities, which is a similar concept that really kind of recognizes these principles, especially when it comes to people living with dementia and their families as well. And so when you think about an age-friendly community, these are kind of the 8 aspects that make up this concept of an age-friendly community. What you see here is that while some of it is really around providing community supports and health services, you can see there's so many other factors at play here. How are we making sure that our outdoor spaces and buildings are accessible, for older adults so they can feel comfortable getting around their communities? Do we actually have adequate transportation services that can better support, again, people to get around their communities? Do we have affordable and appropriate types of housing to allow people to age in the places of their choice? Are we giving opportunities for people to participate socially and making sure that we have these aspects of respect and social inclusion so that we are being inclusive of older people in our decision making and our activities as well? How are we promoting greater civic participation and employment so that we're really allowing people who want to remain in the workforce to stay in the workforce, but also so they can participate in things like voting in elections and other ways? And how do we support people with good quality community and communication and information that can allow them to get the information they need to better support their needs to want to age in place? And you can think so much of this is really interconnected, but really essential when you think about it. So not only do we think about this concept of age-friendly or dementia-friendly communities, but we also can think about other mechanisms that can help people meet these affordability issues later in life. So there are many communities that are offering, for example, property tax deferral programs. These are ways in which you can actually pay, say, what your property taxes are now, but defer any increases until you either sell your house at a later date, when you choose to move elsewhere, or you pass away and then the home gets sold, for example. So that's the idea of a property tax deferral program, and then allows people to not worry about, oh my goodness, I'm living on a fixed income, but I can't afford these constant property tax increases. There's also many programs that focus on improving home accessibility and home modification programs. One of the planks in the recent federal election that a few parties were mentioning was the idea of trying to provide more funding so that people can modify their homes to better age in place, for example. But many communities also offer home renovation programs or supports, especially for low-income older adults. We know that there's one model that I know Heather and team have helped develop in Halton called home sharing. And this is something that's now spread to places like Toronto and Barrie, and is now being spread across the country. And it's the concept where you can actually have older adults who might be what we call overhoused. So they might have some free empty extra bedrooms in their home as kids move out, and this could be housing that they could give to younger people, like students, for example, or others who can pay a lower rent, but offer to help provide support so that person can remain healthy and independent in their own home. There are co-housing models. There are things called life lease models. And then there are also other enhanced home support programs that exist that, again, can really help a person manage the chores and the other activities so they can remain living in their own homes for as long as possible. These are all sorts of things that can be done. But again, how we look at, are we looking at these things as a constructive way so that everybody knows about these opportunities and the ways that we can promote more healthy aging and independent community living? When we think about people who might have some complex needs, but who are living in their own homes, we can start thinking about other aspects. So I talked about dementia-friendly communities before, but there's also this concept of what we call naturally occurring retirement communities. Thinking about maybe an apartment building where a bunch of people moved in 40 years ago when they were in their early 40s, and now they're actually all in their 80s, for example. That's almost a place where we call it a naturally occurring retirement community, and where these are opportunities where we can sometimes cluster various support services so that people can stay more easily living in their own building for as long as possible. There are other examples of various transportation programs at the community level that we can better support people to navigate. There are also community-based home visiting nursing programs or paramedicine programs that, again, can offer people additional supports so they can actually stay in their own homes. And one of these models of home care that's in Iceland and other countries around the world, but not very common in Canada, is this concept of reablement, the idea that if an older person, for example, left the hospital and they're no longer able to independently bathe themselves, for example, instead of just having someone go in to bathe them forevermore, this is where we might see an opportunity to see, well, could we return that person to bathing independently by assigning them an occupational therapist or physiotherapist to basically do an assessment, and then not only have, say, someone help them with the bathing, but maybe also the exercises to practice as well that will get them to bathing independently soon enough. And that's a program, again, an initiative that really works well and can save the home care system a significant amount of money as well. Then we start thinking about older adults who are, again, wanting to stay in their own homes and communities, but need more intensive models of support so that they can stay in their own homes, for example. And this is where these could be people who might be living with dementia or significant needs. And this is where there are good examples of what we call supportive housing models, enhanced adult day programs, for example, and also the idea of the model of care called home-based primary care, a model of care where we can provide support to people who are not able to actually get out to see a primary care provider, but where we need to bring the primary care providers to them through the provision of house calls. And then there are also other models that we call nursing home alternative models. And these sorts of models exist in some places in Canada, but other places around the world. And again, how do we think about these models like the PACE program in the United States or the PRIME or CHOICE programs here in Canada, which have been models to help avoid people ending up in nursing homes as well. And finally, when we think about those people who are living in our long-term care homes, are we thinking about ways in which we can provide innovative models of care? Some of you may have heard of the greenhouse model, the butterfly model, the Eden alternative. These are all kind of models of care that can actually better support the people who are living in these care homes who might have complex and interrelated needs. And often there's other approaches to really support people who might have behavioral issues, especially when the majority of people living in long-term care nursing homes are living with dementias. And about half of the people living in our nursing homes are having what we call responsive behaviors or other issues that sometimes require a different approach to their care to better support them as well. So again, there are things that we can do on an innovative basis across the whole care continuum, but often we've never really looked at it in a holistic and cohesive approach. And again, these are the opportunities that we have in front of us that we need to be advocating for more so that we can have and help create a more sustainable healthcare and long-term care system. When we also think about design considerations, because often we've heard about these older homes that are built to 1972 design standards, what are other design considerations we might want to think about the future types of long-term care homes that we build that can better mitigate viruses that can significantly cause problems? And this is an example of a home called a greenhouse, basically. It's the notion that you have a small home-like setting where you might have a maximum of 12 residents who all have their own single rooms with their own private bathrooms. There's a large common area that's a place for people to gather, but also to dine as well, with a wide open kitchen. And these are sorts of models that have actually shown their worth, especially during the pandemic, because very, very few greenhouses in the United States experienced significant COVID outbreaks, for example, whereas we've seen thousands of homes across Canada and the United States, tens of thousands in the US, that have experienced significant outbreaks. And this is where we need to think about how do we create homes that are spacious enough so that we can consider physical distancing considerations? How do we make sure that we have easy to clean surfaces and furniture? How do we make sure that we have fewer 2, 3, and 4 bedded rooms and better multi-room layouts? So right now, Ontario is no longer allowing more than 2 people to a room, and places like Alberta have announced that they're phasing out anything more than 1 person to a room. And again, how do you think about smaller homes, or what we call smaller geographical footprints with common staff, and remembering always that first and foremost, these aren't facilities, these are homes. And that's why they're called long-term care homes. So how do we make sure that we don't make these settings feel like they're institutional settings, but rather these are home-like environments for the people who need to call them home? So the other thing is that when we think about why we need to be thinking about alternative models of care, it's important to understand that long-term care is not a cheap enterprise, that right now it costs on average about $200 a day to care for someone in a long-term care home. And that's often made up of of not only what the ministry will actually fund a home to provide, but often the resident also has to pay accommodation costs as well, anywhere from $62 to $88 a day. And we know that for 1/3 of the people who are living in our long-term care homes, they can't even afford to pay that subsidy, that amount. And so the government of Ontario often steps in to pay this. Now, retirement homes on average cost the public $117 a day, and that's mainly because they are not subsidized or funded by the government. So again, long-term care options are the cheapest available options for people to live in, for example, when it's only $62 to $88 a day. But again, many of the people in these settings can't afford to actually to live there. And so we also know that not only is there a cost that the government spends to provide the support for people to live in a long-term care home, but we also know that it costs a lot of money to build a bed. So this is what the government is currently funding for developers who are either redeveloping or building brand new beds. And it's anywhere between $212,000 to $268,000 to build a long-term care bed. And so one of the things I did was I did a report that looked at what it would cost to renovate the 30,000 beds that are currently in need of redevelopment across 300 homes. And what about 30,000 new beds that the government has committed to building? Well, that's going to cost us as taxpayers between $12.7 and $16 billion. So this is not a cheap enterprise, and that's just the cost to simply build a home. That's not the ongoing operation costs that it costs to care for someone in one of these homes as well. So as I wrote in this paper about over a year ago, we clearly have choices and options. And really, we know that right now, when a person is waiting in a hospital and they're designated what we call alternate level of care, and they're waiting to either go back home with their home care or to a long-term care home, it costs us about $750 a day to care for them in a public hospital. We know that long-term care costs about $200 a day, but we also know that home care for a long-term care equivalent person costs about only $103 a day. This is the government of Ontario's own costing estimates. So when you realize that it costs half as much to care for a person who's long-term care equivalent or nursing home eligible in their own home versus a long-term care home, clearly we realize that there's probably a more sustainable model of care out there, kind of like what Denmark has done, where they're providing more robust home and community care services so people aren't forced to enter a long-term care home prematurely. And by moving towards a policy like this, where Denmark started aggressively increasing more of their spending to provide more ample home and community care, what they basically saw was they avoided the need to build any new nursing home beds over 2 decades, and actually saw the closure of thousands of hospital beds by strategically investing more in its home and community care services. As well, we know that the Ontario government, while they froze hospital budgets and physician budgets early on between 2011 and 2015, we know that it also committed to a 5% annual increase to the home and community care budget between 2011 and 2018. And we know these investment increases in home care have decelerated since 2018 when there was a change in government, but there also has been a commitment while the home care funding increases have decreased to build 30,000 new long-term care beds in the system over 10 years and to help to try and redevelop the other 30,000 as well. So the key is, would investing in more home and community care actually make an impact? Well, here's the data from the work that I was involved in. So I'll show you on this diagram here. Some of you may have remembered that in 2017 or 2007, the government of Ontario at the time talked about an aging in place strategy. And so put about $1 billion more in to support aging in place. And that was spent between 2007 and 2010. The blue bars represent over this time period the number of people living in long-term care homes who are 75 and older. And pretty much all the folks who are living in long-term care homes are older adults. So this showed that out of the 77,000 beds that were existing, about 75,000, represented older people in particular. And what you can see here is the number of people who are receiving intensive home and community care services, meaning these people were long-term care eligible. And this obviously increased from about 42,000 to about 60,000 by the 2010-11 year. But then this number kind of flatlined, if you will. And then when I was involved in supporting the new senior strategy, we started accelerating the increase in the home and community care budget by 5% a year. And soon this purple line, again, home care recipients that are all long-term care eligible started to significantly increase. So this meant that we were able to support another 30,000 people to receive care in their own homes as opposed to receiving it in a long-term care home by significantly improving the amount of home and community care available. Are we providing enough home and community care today in Ontario? No. But we certainly are providing more than we were back in 2011. And that's made a difference for many, but not necessarily for all, hence why we still have significant long-term care wait lists in Ontario. So what's in store for long-term care? Well, we know that a conversation needs to begin at the provincial and territorial levels to determine how we should approach the future provision of long-term care in Canada and how best to enable aging in place for all Canadians. And while long neglected, the community support and home care sectors are more aligned than ever with what aging Ontarians and Canadians want and will demand upon moving forward. We know the cost to improve nursing home care in Ontario will not be negligible from a future operating and capital infrastructure cost perspective. And finally, we know that promoting aging well will be one of the best things we can do to help many Canadians avoid the need for long-term care in future as well. So this is what I reminded you about, is that what we call our National Senior Strategy. And this is something that I developed back in 2015 with a number of colleagues. And you can find more information about this at www.nationalseniorstrategy.ca. And again, it really talks about these 4 pillars of activity that we really focused on. I've spent the last 40 minutes talking about the provision of care closer to home, but I just wanted to remind everybody what the other 3 pillars are. Number 1, how do we support people to be independent, productive, and engaged citizens? Because we know that older people want to stay active as they age. How do we actually help people lead healthy and active lives? And how do we also make sure that we recognize the 8 million plus Canadians who are providing unpaid care to another Canadian? And so how do we better support caregivers? But now I want to switch my talk over to this aspect here of healthy and active lives, because I didn't want to leave you feeling a bit gloomy about where we need to go, or thinking about why our governments aren't moving more in the line of what we need them to do. I want to leave today's talk focusing on what everybody here can do to lead more healthy and active lives, to promote more healthy aging, and hopefully avoid the need for having to access long-term care services in future. So I really want to talk about strategies for promoting to promote healthy aging, because the reality is for many of us is that we're going to be living to very advanced ages. It's going to be the experience for so many. And we know that life expectancy at age 65, if you make it to 65, is about 20 extra years for Canadian men and women. And we know the majority of those years are going to be in relatively good health. And so the chance that our later years will be ones where we'll be living with dementia also does increase with age. But the great news is that with advances in managing our vascular health issues, like preventing strokes and heart attacks, and better ways to manage high blood pressure and high cholesterol, we are seeing less people living with dementia than we expected. And we also know there are many things we can do to promote aging well as well. So I want to spend a bit of time talking about that. So there have been a number of studies that have actually looked at what does it take to actually lead a more healthy more health, to add more healthy years to one's life. And so this is a study looking at people who are 45 years old and saying, if you're 45 and you do all of these things rather than none of these things, as men, you'll live 7 years longer. As women, you'll live 11 years longer. And this really talked about making sure that one got a regular amount of sleep, making sure that one made sure that their weight was under control, making sure that we regularly exercise, that we limited our alcohol intake, we make sure that we're not smoking, that we're eating breakfast and seldom snacking as well. So again, these are some of the things that have been identified that people at the age of 45 can start doing, and how it can significantly impact their overall health and well-being. We also know that if people do these three things, there are three-fold greater chance to age successfully if people, again, participate in activity, so physical activity, and for a few hours a week, that they've never smoked, that they, again, have moderate alcohol consumption, and that they are trying to eat fruits and vegetables every single day. Another fun study, because some people here in the audience tonight might be older than 75 years of age, and they might say, well, you know, it's probably too late for me, so what's the point? But again, this was a study that showed if you are 75 years of age or older and do all of these things rather than none of them, you will live longer by about 5.5 years. And again, it comes down to this theme of regular physical activity, not smoking, and maintaining, interestingly, meaningful social connections, like getting together on this webinar tonight or meeting in person when you can. How do you actually maintain those meaningful social connections to promote more healthy aging? And what about dementia? Is there anything that people can do to prevent the onset of dementia? Well, we know that the only clear scientific evidence to prevent the development of dementia is by doing clearly these two things. One is getting some regular exercise, and the other one is ensuring your blood pressure is in good order. People doing these things can specifically help to prevent, you know, the vascular consequences of not exercising or having a good blood pressure under control. And while people say, what about brain games? Should I do Sudoku every day, and should I do these crossword puzzles? Isn't that the secret to protect my brain from dementia? And what we do know right now is that certainly that brain games, while they're fun and will make you very good at doing those brain games, they're still not effective ways to prevent the development of dementias, the ways that getting regular exercise or ensuring your blood pressure is in good order can actually do. So these are the things that we need to kind of focus our attentions on, the things that we know we can control, the things we can do to help prevent dementia, but also promote more healthy and active aging. And so these are why I want to share with you some of the things that you can do, you know, in these respects. And then, are there other things people can do to promote healthy aging? Well, absolutely. We should be promoting access to vaccinations. People have always talked about this issue of vaccine hesitancy and thinking that was why so many older Canadians were not getting vaccinated against influenza or shingles or pneumococcal pneumonia or pneumococcal disease. And we know that while people thought, well, it's probably that people just don't care that much. Well, actually, no, that's not the case. When older Canadians know about vaccines that are important for them, we know that right now 94% of Canadians 60 and older have actually received one or more at least one dose of the COVID-19 vaccine, and over 90% have received 2 doses. So we know that older Canadians are not vaccine hesitant, and therefore improving knowledge and access to other vaccinations that enable healthy aging will be important. And that's why we recommend, the Public Health Agency of Canada, frankly, recommends that 80% of older Canadians get vaccinated on an annual basis against influenza and get vaccinated once in their older lifetime against pneumonia. But right now, the highest vaccination rate we've ever achieved has been around influenza at 70%, so 10% less than the PHAC guideline. Around pneumonia, it's only 58% versus 80% according to the PHAC guidelines. And right now, only 28% of older Canadians have been vaccinated against shingles, and that's a concern as well. So again, these are things that people should think about getting, especially as flu season is approaching. Hopefully everybody on this call will be getting their flu shot. But if you haven't had the shingles vaccination, it's a great chance to get it too, because you can get them both at the same time. combating social isolation and loneliness are also things that we need to think about. So again, thinking about older adult centers that are accessible along with accessible transportation. It's no use having a good older adult center in the community where you live if you can't get to and from it, for example. And these can be great methods to strengthen social networks and combat loneliness and isolation. We also know that preventing falls by promoting exercises are good things. And so one of the things we did back in 2013 under the development of our senior strategy was creating 2,000 free exercise and falls prevention classes across Ontario. By making them free, we want to make sure that we had barrier-free methods to help prevent falls and falls-related injuries and combat social isolation and loneliness as well. And so these are just some of the things that, again, we can all do to stay healthy and promote healthy aging as well. So some concluding thoughts on this section are really just saying we are all likely to live longer than we expected. Aging is a normal process, but one that we can make more enjoyable and less arduous by taking care of ourselves along the way. And key things to remember are don't smoke, eat and drink well, but not too well, stay active, watch your BP, stay connected, and get vaccinated, and enjoy your golden years ahead. So thank you very much. I'm going to stop sharing my screen in a moment, and then I'm going to invite Karen, Heather, or Danielle to come back on and allow us to do some questions and answers. And I see that we have about 8 questions already that are in the Q&A box, so that's great. But certainly this is the time to get them in, because I think we hopefully have about 40 minutes, ladies and gentlemen, for you to ask whatever questions you want to me. So I'm ready for that. Now, let me just get myself out of this screen here. Let me do that.
And Heather, if you want to come in and do the bridging, thank you, and then we'll get into the questions, because there are some good ones there.
Perfect. So I'm going to stop sharing my screen, and hopefully we're good.
Go ahead, Heather.
Myself right now? Yes.
Sure.
Yeah. Oh no, sorry. You have a question from someone named Heather. Is that correct?
Oh, we'll get to her in a bit. I'll just give Dr. Sinha a bit of a pause while you go ahead and do a thank you, and then I'll get into the question.
Okay. I wasn't sure if it's now or near the end, but anyway, hello, Dr. Sinha.
Good to see you, Heather.
Yeah, good to see you as well. And we just love the last time you were out, and this just reaffirms everything. And on behalf of the Alzheimer's Society of Hamilton and Halton, and our Hillsview Active Living Center and CARP, and all of us here today in the Halton Age Friendly Network, we really appreciate what you've brought to us today, and so much information. I know when this is up on the YouTube, people are going to go back and look at it and take a breath, because there's so much to absorb. And as you know, in our communities, we are always looking to improve the quality of life for older adults. Interesting when you talk about long-term care being a continuum of care. I really like that idea, and it doesn't institutionalize it, which is really something that we could strive to do, and especially as more people do want to age in place and to have that care at home. And I certainly know many people who are in that situation. And I appreciate your thoughts on the age-friendly communities and dementia-friendly communities, how it promotes healthy and active aging and enhances quality of life for people, and to live with dignity and grace. So I appreciate all your comments, and just reinforces all that we want in our communities and our province across Canada. And I thank you very much for your presentation.
Thank you. Thanks, Heather.
Thanks, Heather. Dr. Sinha, do you want me to go through questions, or would you rather read them yourself? What would you like?
You know what? I can open them up, and I can just start going at them. So happy to do that. It is all
yours.
Okay, perfect. Okay, and then, but I always say you can provide me some parental supervision in case I get out of hand or whatever. So, okay.
All right.
So let's get to them. Okay, so I'm just going to go in order. And we have little timestamps too. So, Wendy, your question was, aging at home sounds great, but what will be done about the isolation? So, Wendy, this is a great question, because often people are saying, everybody talks about aging in place and they make it sound perfect. But, for some people, aging in place might not be the right thing, just aging on their own at home. And so, it can be lonely and it can be isolating. So, is that even practical? Well, I think the key is where I always start is I ask what the older person wants. And if they want to stay in their own homes because that's where they actually like to be, then the question becomes is, again, I have a lot of older patients who like to be on their own. They're not really particularly fond of hanging out with other people, and that works for them. However, there are people, for example, who are social cats. And that while they want to remain at home, they're like, well, they don't want to be lonely. They don't want to be isolated. So that's where we talk about the importance of saying maybe home is where they want to be, but do we have good transportation and other options or ways to help them stay connected, either virtually or physically by getting out to local day programs or to local centers where they can interact with other people? And those are certainly options that we can do, because otherwise people can become quite isolated in their own homes. But for some people, they might say, you know what, I really still find this too lonely and isolating. And so they may choose to want to live, say, in a retirement home. Or they might think that long-term care ends up being a better option for them because their healthcare needs and their other needs can be better supported. So I think the key point is that no matter where somebody ages, the key is to try and address these issues of loneliness and isolation, because we know it can be a huge issue and easily overlooked. And we don't want to think about aging at home at the expense of creating more isolation and loneliness as well. So excellent question. The next question we have is from an anonymous attendee, and it says, hello, I'm curious about what, so I'm going to say it with an anonymous attendee voice, okay? Hello, it's late at night, so it's had a long day. So
it's raining outside.
You're going to get some comedy from me, okay? So it's, hello, I'm curious about what the difference is between LTC health and LTC social in regards to the GDP discussion. Well, that's a very good point. So again, it depends on how various countries around the world classify kind of their spending around long-term care. So in some parts, some countries, they consider this kind of social spending, or they consider it healthcare spending, because they don't think about long-term care as a health expense. They think about it as a housing or social expense. So it really just depends on how countries have classified that spending. And in that OECD study, they wanted to really kind of look at it that way. So in Canada, we consider it a healthcare expense as opposed to a social services expense, whereas some of the other spending that we have for group homes for adults, for example, is something that's funded through a different ministry called Community and Social Services. So it's just, that's the way to look at it. But that was a great question.
Okay, good.
Okay. The next one we have is from Wendy. It says, this is such great information ideas. With these great programs, what will be done for caregivers? It is such hard work. Wendy, you're absolutely right? Again, we often talk about our caregivers as being this invisible workforce. And often we have to recognize that when even people receiving home care, government-funded home care at home, we know that 90% of the care they're receiving is actually through unpaid caregivers. And so you imagine now a person living with dementia, they're probably getting 24/7 care from family members and friends, in order to stay at home. And so we can never overlook that. And so there are various things that we've been trying to advocate for to better recognize and support caregivers. Number one is trying to ensure that caregivers have access to good quality education information so that they can understand how to better anticipate the needs of the person they're caring for. We also talk about recognizing the financial burden on caregivers. The average caregiver spends about $3,500 of their own money every year. So I want people, if you're a caregiver, a family caregiver looking after a spouse or a parent or someone else, to be aware of what we call the Canada Caregiver Credit, something that was established in 2017 and actually is able to help give people up to $7,000 as a tax credit, for example, but that's only if you've actually earned at least that amount of money in order to put the credit against, if you will. So there are financial ways in which we can better support caregivers, including other mechanisms through the EI system to also support caregivers who might have to temporarily take time off work to care for someone who's temporarily ill or towards the end of life. So many people don't know about those finances, but we have to do better about providing more home and community care services and other programs that can provide support so that caregivers aren't burning out in the community. So those are just some of the things that we can do and that we need to better promote so that our caregivers can be better supported. James asked the question, two possible points for comment. Healthcare professionals such as RNs and nurse practitioners are underpaid, underappreciated, and overworked. Also, we need more nurse practitioners. James, I completely agree. And James also said that personal service workers, or we also call them personal support workers in Ontario, are largely immigrants who are underpaid, underappreciated, and have little incentive to stay in their jobs. Again, James, I 100% agree. And one thing that you may not know, James, is that one of the things that really bothers me a lot here in Ontario and many parts of the country is that nurses and personal support workers who choose to work in the community, in community home care settings or in community support services settings, often get paid far less than people working in nursing homes, who get paid far less than people working in hospitals. So literally, I always say the further you walk away from a hospital, the lower your wages go. And that doesn't make it, that means that really, while we're paying people, and that really wreaks havoc on our ability to provide adequate home and community care services, and even long-term care services. So you're absolutely right. If we don't pay people well enough, and we actually don't give them better conditions of work, then people are going to have very little incentive to stay in their jobs. And that only creates turnovers. In fact, what we saw prior to the pandemic was about 80% of homes were reporting that they were having trouble meeting or adequately recruiting people as well. Okay, I'm going to keep racing through these unless Karen, you want to interrupt here. But I see that, okay. So Diane, you've got 3 questions. Okay. So we're going to try and ask people to limit to 1 because I got 27 open questions to get through here. Okay. So what does Dr. Sinha recommend to the public to advocate for some of these things to be implemented? How can we influence the government? Okay, well, that's a great question. So remember that website, nationalseniorstrategy.ca. That's one place where you can read up on what we need to do and where we can invite you to advocate with us through the National Institute on Aging. So Diane, take a look at that website, www.nationalseniorstrategy.ca. That's where you can get educated. That's where you can advocate. And that's certainly where we're always looking for more people to get the knowledge so that, again, when politicians are trying to earn your vote, you can help to advocate for that. And you can follow a lot of the work that we do through the National Institute on Aging because we try and help to distill the information here into actionable policy. And we've been able to get a lot of victories over time. But again, we need more support from some smart people like you. So your next question was, when working directly with families, it can so often feel like we are constantly driven by a lack of basic resources that to consider big picture objectives, despite the fact that we recognize their long-term value, both financial and in servicing our families, can feel overwhelming and beyond reach. How do we start to make the change happen? Well, I gave you some examples, Diane, of just things that we started to do in Ontario when we became the first province in Canada to have a comprehensive senior strategy. The problem is that politicians, have very short attention spans, and they work on 4-year electoral cycles, right? They're always thinking about, the number one job of any politician, remember, is to get reelected. That's their number one focus. Then it comes to their various portfolios and things. So I think the key is it's important for all of us to be educated on what is the goal that we need to get towards, and then how do we seize the moment and the opportunities to slowly work towards that. But with some of the investments that we made in improving home and community care services and other things, we were able to move the dial forward in Ontario, but there's still a heck of a lot more to do. Okay, Ellen. I'm not keeping up with the question. We got 28 open ones here.
Keep going, keep going. You're doing good.
Okay, here we go. Okay, so what programs, policies are in place or on the drawing board to address the needs for increased numbers of PSWs and nurses required to support seniors remaining in the home setting? So, Ellen, good question. So I think the government of Ontario was quite pressured by the fact that right now the average person in a long-term care home is receiving about 2.7 hours of care a day, even though the government of Ontario's own expert panel said that we should be providing 4 hours of care a day. So the government has finally committed towards doing that. They've committed to doing that by 2025. And that means that they'll have to at least hire an additional 27,000 new frontline workers to actually be able to meet the 4 hour a day standard. So there is money being put in the system, but the challenge is how do we, back to the previous questions that James was asking, how do we make sure that we don't create more of a revolving door, but making sure that personal support workers and nurses are adequately paid, and that they're given the right support so that they'll want to stay in these roles and want to be attracted to work in these settings as well. So these are some, go ahead, Karen.
Sorry, is there any research to show that if staff are well supported in long-term care and the home care setting, there's a lower burnout rate?
Absolutely.
Yeah.
I mean, think of it, right? So, Pat Armstrong, that some people may know of, she wrote many years ago that the conditions of care, conditions of work, translate into conditions of care. People receive better care. Staff are less likely to turn over when they feel happy, appreciated, and supported in their job. Think of it, if you don't like a boss or you don't like what you're doing, you're going to leave. And if you get paid better money to do something elsewhere, you're going to leave. So this is the challenge that we have. Okay.
I'm going to let you skip Diane's next question. Okay. I know Diane, so go ahead.
Okay, perfect. Okay, you know what? So we're getting through these. Okay, Margaret, we're on to you. When would an older person see a geriatrician as opposed to a family doctor? Right. So great question, Margaret. Everybody should have a family doctor or a primary care provider. You might have a primary care nurse practitioner or a family doctor. I highly recommend that if you're an older person and you have multiple chronic issues or challenges, it's hard to really get the best care from a solo family doc. So a doc who's just working on their own. I often say that if there is something called the community health center or a family health team or a group practice, for example, sometimes it's better, but try to find a family doctor if you don't have one. Try and find one that's working in a group practice, for example, because then you can often rely on the benefits of a whole healthcare professional team. And really, when is it valuable to see a geriatrician? Well, certainly geriatricians are often consulted by family doctors when there might be a particularly complex issue or challenge. There might be a person on many medications, have many different complex issues, and they just want someone to do an overall, what we call a comprehensive geriatric assessment to help that family doctor understand what are the next things that they can do to better move things forward. Okay. The next question is Peggy Dobbins' question. How can we advocate for the changes you described around long-term care and home and community care? Well, first of all, Peggy, get educated on these issues. And so that's why I was talking before about the national, our national senior strategy and looking there to understand those issues. And then really, I mean, once one knows what the issues are and gets educated, again, we have a weekly e-blast we put out through our National Institute on Aging. It shares with you the latest articles around aging and what we're advocating for. We were giving lots of commentary around the recent electoral platforms, how they've been doing, how they're not doing well. And it really helps that you as a voter becomes more educated to make sure that whatever party you belong to is actually taking your issues seriously so that we can get the changes that we actually need. So I would say get educated and then get politically active. And that can be done through a variety of organizations as well. So Seema asked the question, is in the National Aging Strategy, are there any strategies to support family, informal, or family caregivers? Absolutely. So that is absolutely something that we focus on. Remember when I showed you the 4 pillars, the 4th pillar there was all about support for caregivers. So if you want to learn more, you can go to our website, nationalseniorstrategy.ca, and you can read specifically about the things that we're advocating for to better support family and unpaid caregivers. Diane asked the question, I have heard that if you are over 80, your chances of getting shingles is slight. Is that true? Diane, this is a great question. The answer is it is far great. You are far more likely to get shingles if you're over 80, and heck, when you get over 90, you're far greater. So we know that the reason why we basically recommend that anybody over the age of 50 get the shingles vaccination, because the key thing is as we get older, our immune systems start to weaken. Think of it as the concept of mileage, that as we age, our immune systems become more immunocompromised, just because, as we age, our our immune systems don't work as well as they once did. That's why young children whose immune systems are starting to develop need vaccinations. And that's why older adults start needing vaccinations like influenza, pneumococcal, against pneumococcal disease, shingles, COVID-19, because again, when you actually look at where the burden of deaths and hospitalizations and other things occur, it's usually in that older population. And so in particular with shingles, we know that the older you get, the greater likelihood that you will get an attack of shingles as well. So we are actually, our National Institute on Aging is about to launch a white paper, a policy paper, all around shingles. And so hopefully you'll keep an eye out to that, because if you do, you can read all about it in a very detailed report we've written over the last year or two that we're going to release this fall, that really kind of helps talk about why more adults need to, because we know that it's a vitally important vaccination. It's why Ontario and I believe PI and the Yukon all have now introduced programs or are introducing programs to provide the shingle vaccination free of charge, but for certain populations, I believe the 65 to 70-year-old cohort right now. But if you are over 80 and you haven't had the vaccination, totally you should get it. It's money well spent. Okay, next question is, it has already, if one has already had shingles and it's in one's body, is there any value in getting the shingle shot? Absolutely. You know why? Because if you ever had chicken pox, then you are prone, because that's the same virus, the varicella zoster virus, that is actually the virus that causes chicken pox, is also the virus that causes shingles. Basically, that virus lies dormant in your nerves, and then it reawakens if you might become more immunocompromised over time, and or say, or you feel if you have a health condition or other things, then these are things that can trigger a shingles infection in a more vulnerable person. So if you've had shingles, guess what? Your chance of having shingles again in future is much higher. And if you even had the shingle shot before, for example, some people might have had what we call the Zostavax, the old vaccine that was first introduced in 2005. And that was a single shot vaccine. That vaccine is about 50% protective against getting shingles. But the new shingles vaccine that's been available since 2018 is called Shingrix. That one is about 90% protective against getting a future case. So if you've already had shingles, or if you've even had the single shingles shot, I highly recommend you get the new one, because that will give you the best possible protection moving forward. And it's not so much about getting a case of shingles, it's more the complication that commonly happens with shingles called PHN, or post-herpetic neuralgia. That's the painful pain syndrome that people often get where the virus was. And that can be quite debilitating. So I've had too many older patients who have resisted my urges to get them to get the shingles vaccination. And then they've come back to me and said, Dr. Sinha, please force anybody you meet with in future to get it, because just go on the internet and see what it looks like. It ain't pretty, okay? And it's something that you can take advantage of. Okay, Wendy's question. This is an excellent thing. This is excellent. Thank you so much. Also, transportation is such an issue in rural areas. 100% agree that, again, we can't think just about what we're doing in urban settings, but again, all these issues I've talked about become even more important in more rural and remote areas, because when we don't provide these sorts of services, that significantly increases the risk of someone ending up in a nursing home. Okay. Pat O'Sullivan says, any plans for interim care for dementia people, like small group supportive housing when family care isn't available and long-term care isn't yet needed? You know, Pat, I don't know of any plans right now, but it would be a great option. Certainly, we do have some excellent models in Ontario and in Canada that were built long ago. One that I actually work with called Ewart Angus House. It's actually, it's located in downtown Toronto. It's run by a community agency called Sprint Senior Care. And I think Ewart Angus was an industrialist out of Hamilton, of all places, who then donated money, I don't know why, to this organization to build this special house, but it's a lovely home, 2 levels, 10 people per floor, all living with dementia who don't quite need nursing homes, but need a little bit of support and supervision. And it's affordable too. So it's a great model that really can actually save the government money. I just wish the government would do more of that. So Pat, we do have solutions like this that are great examples in Ontario. We just need political will to do it. Okay, back to our anonymous attendee. Says, is the demographic care needs of residents in long-term care homes similar in the countries that are shown in your comparisons? It's a great question. So what we do know is that there are countries, so I was just in Iceland working with their government and their Minister of Health and team, and what we do know is that people in Icelandic nursing homes are not as frail as people in Canadian long-term care homes, mainly because in Iceland, they spend about 92 cents on every dollar warehousing people. And in Iceland, literally, they have such a culture of just putting people into nursing homes because they virtually have a really poorly funded home and community care system. So the basic premise is if you can't walk to your family doctor's office, you belong in a nursing home, which was horrifying to me. I'm like, what about doing house calls? So again, they're now rethinking this policy because they're realizing the system is completely unaffordable. So we actually do know that there are countries where the people in what we call nursing homes or long-term care homes are not as frail and sick as the people we have in ours. And certainly in Canada, we've made much more deliberate efforts to try and reserve this expensive form of care to people who really, really, really need to be there. But still, CIHI, or the Canadian Institutes of Health Information, say anywhere between 10 to 30% of people living in these homes probably don't need to be there and have entered prematurely. And especially we know that people living in rural and remote communities have a much higher, greater chance of ending up in these homes when there's a lack of services available. So we did that one. And then the next question from anonymous attendee is there any discussion regarding the size of LTC institutions? Yeah, there's discussion, of course, and I talked about this idea of the greenhouse model, these smaller home concepts, but the challenge is the current way that Ontario funds the building of new long-term care homes is it's economically, the funding formula basically encourages people to build 32 units or 32 beds per kind of unit and homes with at least 120 beds in them. So right now, there isn't really the funding models or mechanisms out there to really kind of encourage the building of those small home-like settings like we call greenhouses in other countries.
Yeah.
Okay, Susie Duncan says, do you think that the stigma that is still unfortunately associated with aging and in particular dementia is deterring our aging population's ability to age in place at home? For example, stigma perhaps stopping individuals from accessing services that would enable them to age well, like such as ADPs and support groups. Yeah, I think there's some stigma, Susie, but I think the problem is that we're just really not doing enough to help people age in their own places, in their own communities. So yes, there is stigma around aging. People don't want to age. People are embarrassed about the ideas of dementia and these sorts of things. But I certainly think that we obviously have to do a lot more because I don't think we have enough adult day programs available. I don't think we have enough support groups for caregivers and other people. And I think if we had more of these things available, we would show people that there are ways in which people can positively live better in their long-term care homes. In their own homes for as long as possible. So I don't think there's so much of a stigma against those things, but I think certainly sometimes where there's stigma, people don't want to access services, they make things more difficult for them to live in their own homes. That might prematurely end them up in a long-term care home. And that might be what you're getting to, Susie. So we need to decrease the stigma and make sure people can better access the support that exists. Ellie has a question saying, would it be possible to have a PDF of your presentation? Absolutely, Ellie. I'm going to remove 3 spelling mistakes I came across in my presentation, and then I will email it to Heather, Karen, and the gang. And then I'm sure they would be more than happy to post it or distribute it to those who registered today. So Absolutely. There you go. That was an easy answer.
Thank you.
Anonymous attendee says, care providers for all these options are key. Staff being properly trained and general staff availability is a concern for long-term care, but even greater staffing issues in the community to support those at home. Thoughts on how to advocate for equality in the staff roles compared to hospitals, or any out-of-the-box ideas? Honestly, I think we know what we need to do. It's just, again, a government funding commitment. So right now, this government has continued to create temporary wage enhancements for PSWs, but they're not really willing to commit to it overall. You heard in the federal election, you know, I think the winning party, the Liberals, talked about giving money to governments to try and raise the wages of personal support workers to $25 an hour. Some of them are currently getting only $16 an hour in terms of the work that they do. So again, if you don't pay people, you know, well enough, you know, why are they going to want to do that work when they might potentially get more money pouring coffee, for example? Nothing wrong with that. But again, we have to remember that providing care to vulnerable elders is complex work, and it needs to be respected as such as well.
Mm-hmm.
So, anonymous attendee, regarding size, a 270-bed facility is never going to feel homey. I agree. Okay, that was easy. What blinds governments to see the great savings to be done through offering home care rather than building more facilities? Well, Gabriella, I think what blinds governments is large donations from developers who really just want to you know, get a piece of that $12 to $16 billion that will basically be spent on building more beds and so on. The government's own data shows, you know, that, you know, providing better, more home and community care, keeping people at home is actually the viable thing to do. The literature is overwhelming to this. But unfortunately, I always think that sometimes politicians, you know, are kind of, they like the idea of ribbon cutting in front of buildings. They think that building buildings is the solution, but it takes 4 to 5 years to build a new home. Just investing in more home and community care, training people, you can actually make a significant impact. And I already showed you some of the data on what we had done, but somehow that wasn't good enough. So I think countries, you know, eventually, as we have more educated electorate and more older people, I think eventually governments will be forced to do the right thing. But there are smart governments like Denmark that figured this all out in 1988, and frankly have really good data to show for it now. So those are my musings as to why I think that there's this love of building and building and building expensive buildings and having these developers do it. There's good money to be made in that. So, okay, Daniela, what are the best advocacy groups that can pressure the provincial governments to understand the financial other benefits? Well, I would think, Daniela, that my organization, the National Council on Aging, is probably one of the best out there. You know, CARP is also an organization that's always quite active. My colleagues at CanAge, there are various organizations that are out there. And it's good to kind of look around and see what it is. But I would encourage you, you know, to go to if you go to www.ryerson.ca/NIA, if you look up National Council on Aging at Ryerson, you can come across our website. You can sign up for our newsletter. These are ways in which you can constantly get educated on what needs to be done and learn about the policy opportunities as well. So hopefully, Danielle, that gives you a sense of more ways to get involved. Okay, type your answer, cancel. I think I answered that. Okay, Margaret says, do you have any suggestions for communicating these great ideas on home-based care to our political representatives? Absolutely, that's why I'm on all the time, you know, and putting out our evidence briefs and doing that. So certainly, you know, I think the key is the best way for political representatives to get the messages when everybody's singing from the same hymn book, if you will. So again, we've been really working hard to kind of get the right knowledge and the information out there. And we really welcome you and others to kind of, again, get educated and being able to kind of, you know, really hold people account. So there are, you know, so we encourage you to get involved because these are ways in which we can repeat these messages so that they'll finally hear that there's only one way in which we want to move forward. Mary says that any suggestions on how we can get family docs to diagnose dementia earlier, soon? People with dementia can be more involved in their care planning. Mary, that's a great idea. One example, one great idea that started in the Waterloo region was the idea of what they call MINT clinics. So I don't know what they stand for, but they're basically memory clinics that are developed and run by primary care teams, for example. And they have, I think, over 100 of these across Ontario. And so it really gives an opportunity now where if many family doctors have not received any geriatric training, unfortunately, in their training to become family doctors or in medical school. So I don't blame them when they may not necessarily have all the training to make these diagnoses. These diagnoses, in my view, are not necessarily very hard to make. For example, it takes a bit of time and a bit of effort. But I think the key is that we are starting to see various models being suggested that could be quite effective in supporting primary care providers to feel more comfortable making the diagnosis. Because you're right, getting an early diagnosis can allow both individuals and their families to better support themselves if they're living with such a diagnosis. Mary also says, would it be a benefit for long-term care to be a part of the Canada Health Act? Absolutely. You know, I think it was something that was never put as part of it back when we created our Medical Care Act, or Medicare, back in 1966. In 1984, the Canadian Medical Association, others were advocating that we stop neglecting long-term care and we stick it in to the Canada Health Act as well, and it never got done. So I don't know, you know, there's a lot of debates about if we reopen the Canada Health Act, it might actually create a whole bunch of other problems along the way. But right now, I think the federal Liberals are talking about creating some kind of National Long-Term Care Act. Not sure what that's all about or what they're planning to do. Maybe it's to help enforce the new National Long-Term Care Standards they have me making. But, you know, I don't know. But I really think the fact that long-term care is not recognized as part of our Canada Health Act and our universal healthcare system, same with pharmacare. I think these are problems because if you go to other countries like Denmark and other places around the world, they've actually made their universal healthcare system consider these parts as well. Okay, Suzanne, okay. Do you know of seniors who might live in a hotel or live on a cruise ship for the remaining years? Yeah, you know, honestly, it's a phenomenon. It's a thing where there are people who say it's actually cheaper for me to go on these endless cruises, you know, these discount cruises for the rest of my life. I actually don't think it's a bad idea, to be honest. You know, I've been contemplating it myself. And thinking about it as well, right? Like, think about it. If you're living in a retirement home, you're kind of living in a hotel. You know, there's food there and that, but you never know, right? You know, you could think about where you can go, and you know, you can go live in the best Marigold hotel. So people, you know, do think about these things, and it's not a silly question. Debbie asks, I live alone with no children or other family to support me if and when I develop dementia. There's a pretty strong dementia on both paternal and maternal side of my family. I've just finished 2 consecutive caregiving journeys. How can I best prepare for my own dementia journey with no prospect of caregiving support from my family? So you know what, Debbie, you know, it's a great question, and I can appreciate the anxiety that someone would have saying, you know, if I get dementia, what will happen? And we know that the older we get, you know, the greater likelihood we might end up living with the dementia, right? So in our 80s, 1 in 3 older people could be living with dementia. In our 90s, 40%, over 100, it can be 1. So, you know, I gave some tips already, right? Is make sure that you keep your heart healthy by getting regular exercise, making sure that you're getting your blood pressure under control, if you know, and keeping it under control. So these are sorts of things that you can do, for example, but also make friends. You know, Debbie, try and make some friends, for example. So the idea is if you make friends, you know, you're more likely to have people in your life who might help pitch in and be able to provide you some support, for example, as well. So think about kind of ways in which you can make friends, and then think about your home and the way it's set up. Right now, it works well for you, the way you have it set up, but will it work well for you if you're living with dementia? So, you know, I read a good friend, Lindsay Green. She wrote a great book back in 2013 called The Perfect Home for a Long Life. I read it, and then I made my housing purchase, which is a single story setup. So I live on 1 floor of an apartment building. It's above a nice restaurant. So that's my Meals on Wheels plan. And it's single story, and I have all the door widths are all at least 36 or at least 42 inches wide. And why? Because the international width for wheelchairs and walkers is 32 inches. So I've kind of thought this thing through, and these are some things that you can do, Debbie, while you're young and able, is to kind of think about, is my home adapted for me as I age, and what are the things I can do? So those are just some of my tips. But make some friends, because that way you won't be without any family, but you might be with some others, or you make a pact that you'll look out for each other as you age. Okay. Angela asks, for example, as a full-time caregiver to my 90-year-old mother living in West Toronto, where are the community sector seniors social gatherings that aren't costly? She needs it. Well, you know what? In West Toronto, there are great organizations. There's West Toronto Supports for Seniors. There's Reconnect, for example. There's also West Neighborhood House. These are some great organizations that do have that run various kind of what we call older adult centers or elderly person centers, seniors active living centers. I would look up these things because, again, there are many of these organizations. They're free to join, be a part of, and these can be a great opportunity for people to get involved with these clubs and these activities. Okay, we literally have 3 minutes left, and
I was just going to say one more question. I think that's it.
One more question. They said the Canada Caregiver credit is not available once the disabled person's income exceeds $24,000. This needs to change and to no income limitation. The disability tax credit is not based on income. The caregiver tax credit needs to be the same. I agree, Anna. And these are the things that we identify, that while the Canada Caregiver credit, it's better than nothing. Beforehand, they used to have these $400 tax credits, but you couldn't get it if you, like, for example, you could get it if you were married to someone, but not if you were living together. Weird. So very few people were taking those up. So this Canada Caregiver credit is better than nothing, but we've identified some of these issues that need to be rectified to make it better. Okay, so I'm going to stop there. And I think I did okay because I think we answered 36 questions.
You did very well.
So I'm going to stop there and I'm going to pass it back over to Karen.
All right, lovely. Obviously, Dr. Sinha, that was amazing. Thank you so much. And you're so full of information and very quick with wonderful answers. And as an educator, I really, really appreciate that. I have a wall of Post-it notes of things that I'm going to follow through on after this. So I really want to thank you for the time and the care that you took in sharing all of this information. As a follow-up, we will be sending information to everybody. You mentioned a few resources. We'll attach them as well. And I think I'll just wrap things up because it is 8:30. So I do want to thank you so much. And thank you for coming out all the way to Halton. Much appreciated in Hamilton. Thank you so much, everyone, and keep your eyes open in your inbox for your survey that will be coming through. Thanks, you, Dr. Sinha.
Take care.